Hello everybody. Today we are with Dr. Sudipta Sekhar, who is from Kolkata with us, and this is a thing that we always wanted to do. We wanted to have an interview with him for autoimmune hemolytic anemia and basically DAT and other things pertaining to direct antiglobulin test. My name is Dr. Mohit Chaudhary and this is the new episode of TransConnect. So before I begin, I just wanted to tell you, sir, that this TransConnect is a thing that we have started, and this is basically for the DNB students and the trainees, how they for learning about transfusion medicine and questions pertaining to them both practically and theory. And since you are an expert on this, firstly I would like to know something about you. What made you come in this field, first of all, and where you're working and what you do.
Good afternoon, and first of all, a good initiative taken by Dr. Mohit, where the DNB and the ND students, not only in this hospital or in this city, so in the entire country will be beneficial for this TransConnect program, where different experts will come and talk on some topic related to transfusion medicine or immunohematology, or it may be a clinical transfusion medicine also. Okay, so myself, Dr. Professor Sudipta Sekhar, I am the director and the head of transfusion medicine and blood center, Apollo Hospital, Kolkata. I am an MD in transfusion medicine and postdoc in transfusion medicine from SGPGI Lucknow. And since last 12 years I am in Apollo Group as the head of transfusion service.
Thank you. So coming to the topic itself, I know you are an expert and you've been doing AIHA and a lot of work on autoimmune hemolytic anemia. So my first question to you is, sir, for how much time you have been, when was the first time you actually started with the AIHA testing?
Yeah, basically I started my AIHA work since last 20 years.
Very nice.
In 2003, because that was a topic given to me as a part of my thesis.
Oh, very
right.
Nice.
So at that time, very less were known regarding this AIHA workup, in particular in the blood bank section, and that there are no any battery of diagnostic tests also to confirm what type of AIHA is there, how severe it is AIHA, right? So we started from the simple DAT by a conversion tube technique. Then with the more innovative techniques in our country, gel card or column agglutination, SPRCA and microplate techniques. Okay, so then we actually had an advancement in the diagnostic part of AIHA.
Nice. So it's been more than 20 years now?
Yeah, right.
So good. So that brings me to our very basic questions, which I would like to know, in fact, and my DNB trainees would like to know, is what is the role of autocontrol? And what are the temperatures that we should put in, and what is the significance on each temperature? Whenever we do a DAT test, we are told that we should run an autocontrol. So I want to know, do we put it in different temperatures, and what is the role of each?
Yeah, you see, autocontrol, suppose a DAT is positive or a ICT is positive, it can be due to an alloantibody also. Particular DAT is positive when there is a recent aluminization in the last 2 or 3 months, and your transfused red cells are present in the circulation, and gradually this DAT actually goes off after certain time, right? But if it is an autoimmune autoantibody, your DAT will be increasing gradually, and your autocontrol is very important, because that will help you in differentiating whether it is an autoantibody or it is an alloantibody, right? And as we were saying about the thermal amplitude of autoantibody, so always as far as my clinical part is concerned, transfusion medicine is concerned, what I have seen in the last 20 years, it is always wise to put autocontrol in various thermal amplitude, but for that we should know the thermal amplitude of the autoantibodies that you are dealing with. For example, if you do a DCT only, that will only tell you that your red cells are coated with some autoantibodies, right? Say it may be a IgG or it is a complement or both. But if you do a monospecific, or what we call it as a disease screening, right? And nowadays in the literature they call it as a supercombs. Okay, so monospecific DCT or a super Coombs or a extended Coombs or a disease training, ultimately the test is same. The terminologies are different,
right,
and we use this terminology in a different way in different countries and different regions, right? So when you do a monospecific, so it will show you whether it is an IgG alone or it is IgG with complement or not, or there is an associated IgA with the complement or IgG. So that will give you a broader picture of the autoantibodies which are coating the red cells, right? So once you know that you are dealing with multiple autoantibodies coating the red cells, right? Then again here on the right side, say serum test, you want to know that whether you are dealing with a warm or warm with a cold, right? So in that case, it is always wise. I will prefer doing an autocontrol in various thermal amplitude, right? Along with your thermal amplitude of the antibody that is circulating in the serum. So if you take a pooled dose cell with the patient's serum and put it in 4 degree, 22 degree and 37 degree, similarly in the same way, in the same go, you can put an autocontrol at a 4 degree, 22 degree and 37 degree. So that will give a very clear picture whatever autoantibody you are dealing with and at what thermal amplitude it is working.
Okay. So that is right. So if to put it, you advise that we should put it in 3 different temperature or 4 different temperature. So would you say we should put in 4 degree and 22 degree, because some people omit one of these? So do you think that we should put in all the 4 temperatures, or we can make do with 3 temperatures?
Yeah, actually what happens, we should not omit the 22 degrees centigrade, right? Because that will not give you the broad spectrum of temperature you are dealing with. Okay, suppose sometimes we say this is an autoantibody which is reacting at a wide thermal amplitude.
Right.
So when we are talking about the wide thermal amplitude, if we are talking about a warm antibody in a wide thermal amplitude, that means it may react from 20 degree to 37 degree, right? So if you don't put it 22 degree or a room temperature, what we say, then you tend to omit that, right? Now again, if you talk about a cold antibody, they may react at 32 degree also. Obviously room temperature 4 degree. So again there is a wide thermal amplitude, and notoriously in mixed AIHA they tend to react more in this room temperature, and it has a tendency to react at 32 to 34 degrees centigrade also. So that will give a clue of the autoantibody which you are actually dealing with at that time.
So if I may gather, you have said that we go for a polyspecific. For listeners, polyspecific means it is a combination of IgG plus C3d. Suppose that comes positive, we go for a monospecific to know which of these antibodies is positive, whether it is IgG, IgA, IgM or C3, and then we also go for a thermal amplitude to check for the temperature actually at which this antibody is reacting.
Right.
Is that right?
Yeah, that's right. But you will be doing a thermal amplitude on the
serum itself.
Serum, okay.
Yes.
That is a loose antibodies or free antibodies which are on the serum. But first you should confirm whether you have autoantibodies in the serum or not.
Right.
Because all DCT positive will not be ICT positive or something, right?
Course, yes.
Because the actual character of the disease is like that. Suppose the patient has started forming autoantibodies. So once it is formed by the B cells, right? So it will come to the circulation and it will be binding to the red cell. So it will be 1 plus, 2 plus, 3 plus, 4 plus, super saturated. Then gradually it will come 1 plus, 2 plus, 3 plus, 4 plus ICT. So DCT positive doesn't always mean your ICT will be positive. But yeah, in a long run, if the disease is going to a severe stage, the ICT will be increasing. Okay. So first you have to prove that, or you have to see that whether you have autoantibodies free in the serum. Then the thermal amplitude and other things will come into play. But suppose your ICT is negative, then what will happen? And your DCT is positive, then you can do an elution. Okay, because once your red cells, your autoantibodies are bound to the red cell, you cannot have the red cell free, autoantibodies free. And once they are not freed, you cannot do the characterization of the antibodies.
Right.
To free the autoantibody from the red cell, you want an elution. Right. Once you get the eluate, right, then you can put the thermal amplitude again to see the character of the antibody.
So, just further to this, which are the is there a grading strength with which we should elute, or you think even in 1+ or 2+ we can still go for an elution and then do a thermal amplitude?
That is a very good question actually. So I have done more than say 500 elutions till date, right? So what we have seen that if you are skilled to do elution, you can elevate even if your red cells have a reactivity of 2+. But 1+, many times you will not get an elevate positive.
Right.
But sometimes if your DCT is negative, your elevate may be positive, which is signifying that you are dealing with a DAT negative AIHA.
Oh wow.
Yeah, that is also in the other way, right? So elution is very subjective actually. Sometimes in 1+ you may not get an elevate positive. Again in 2+ also somebody misses out if you are not a skilled person, right? But in 2 to 4+ you should get. 1+ you may not get. But sometimes in that negative AIHA you can get a elevate positive also because they are concentrating the antibody.
Right.
Yeah, that's the beauty.
So sir used the term DAT negative AIHA. Sir, would you like to elaborate a little bit for the users, because there are some first yearites also?
Yeah, actually that is a different topic totally, right?
Yeah.
So why you call is DAT negative? Negative by what technique? That's
Right.
important, because a lot of techniques are now
Not so
right?
sensitive.
Yeah. So now the gold standard technique is the conventional tube technique, right? So we define DAT negative AIHA when your DCT or DAT is negative by conventional tube technique, CTT. And tube technique, the sensitivity is around 400 to or more than 400 autoantibodies bound to the red cells. So if it is 300, it may give a negative report, which may be positive by your column agglutination or a SPRCA, because SPRCA column agglutination, they can detect autoantibodies bound to the red cells to the tune of 120 molecules, right? Plus molecules. Now, again there are terminologies like ELAT, enzyme-linked antiglobulin test, right? So this ELAT, there was one immunohematologist in 1970s and 80s, R.J. Sokol. Right? R.J. Sokol was the first to introduce this ELAT antiglobulin test for DCT in 1970s, 80s, and he found that you can have a DCT positive when your autoantibodies coating to red cells are in the tune of 80 to 100. Okay, but we tried this ELAT during my MD days at SGPGI, but it was a very cumbersome technique, right? Maybe one DCT will take the half of the day or the whole day. Okay, so we have to actually calm down, right? Now there is the most sensitive DAT technique is the flow cytometer, right? Flow cytometer, which can detect around 35 to 40 molecules of autoantibodies bound to the red cells. But it is a very good thing, right? DAT negative, but it has a high false positivity.
Right.
If I test my red cells or your red cells in the flow cytometer, you may be DAT positive, I may be DAT positive.
Right.
Okay, because IgGs are there in the circulation,
Yes,
and often on they stick to the red cells. So, but always remember that the conventional tube technique is more specific. If it is DAT positive, that means
that is positive.
And gel curd and other column agglutination or the glass bead or the microplate, they sometimes have a tendency to give a more reactivity strength, or it may be sometimes false positive. It may not correlate with your immunohematological markers or in vivo hemolysis, right? So this was so DAT negative AIHA. So what happens actually? How this term came, I will tell you. Actually, in the conventional tube technique, what we used to do, we wash the red cells, right? Then spin the red cells 3 times, 5 times, whatever. Sometimes washing of red cells detach the loosely bound antibodies.
Okay.
Suppose there are 600, after washing, there are now it comes to 300.
Right.
But you have to wash that.
You have to wash that.
Otherwise, there will be unbound antibodies.
Yes.
That's necessary, which can be actually bypassed by your column agglutination.
Right.
So you get in column agglutination 600 molecules, but washing and other things may lead to dissociation of the loosely bound autoantibodies. So you may land up with a negative DAT. So Garrity, who is considered to the father of immunohematology, he introduced one technique, is a cold DAT.
Right.
So all the DAT will be done in the cold phase, cold saline, cold everything, right? So there is a cold DAT, right? So he said that if you do a cold DAT, then it will the loosely bound autoantibodies are shed out to a lesser extent, right? So that is a colder DAT, right? But in research institutes or in say referral institutes, right? Hospitals or immunohematology labs. Apart from the column agglutination, they are also using the flow cytometry for that, right? Flow cytometry is said to be one of the good platform to diagnose this DAT negative AIHA.
Right. So moving on, I see that you have been well versed in all the techniques for that. So which is the technique that you would like to advise that one should go in a tertiary care center, especially like yours, for detection of DAT? So and or we can choose between the few.
Yeah, see, if I sit here and say, just to my mind it is coming three techniques, right?
Right.
One is the conventional tube technique. Always we have to talk on that, because in the government blood banks and the other in the peripheral blood banks, they don't have the column agglutination. So conventional tube technique is always there, so it is a gold standard. Then comes the column agglutination, right? It may be a gel card or the autoclinical diagnostics glass beads or a tube gel, a lot of commercial available.
Yes.
And third is what you have said, the SPRC or the microplate system. Okay, you can do that with this one also. But I will not go beyond that. I will not come to ILAT or flow cytometry.
Right.
What we do actually, what my protocol says, always we do that using two techniques.
Okay.
Conventional tube technique is always there from the very beginning. Apart from that, we put a parallel column agglutination also, right? We don't do that by microplate, right? Since we are having this column agglutination from the very beginning, we are into that, right? As per my SOP, it is done in both technique, column CT conventional tube technique and the column agglutination tech. Yeah. And CTT cannot be erased, because in many blood banks they use the CTT. And of course, column agglutination, we are like corporate hospitals, they are doing the, right? But sometimes we should remember that there may be a tendency to have a false positivity or falsely high grade of reaction in that by your this sensitive methods.
Right. So you're right. I mean, whatever techniques you have, I mean, you can do that. But more or less, these three techniques which you have mentioned, you can adopt any one of them. And in fact, you should have two techniques so that you can always play around with the techniques.
Yeah, we have done a study also
right.
comparing conventional tube technique as a column agglutination, and the beautiful results have come. It is available in the literature also, in the PubMed search also.
Right.
The students can refer to those also.
Yeah.
Discordant result, concordant result.
Right.
Comparing
between the techniques. Right. Good. So the other thing that we kind of struggle, and a lot of even I try to find out the answer for that, is the cold agglutinin titer. So many a times, we have these benign antibodies, cold antibodies, which are non-specific in nature, and they would like to, they tend to interfere between the blood grouping and other things. And we don't know whether it's cold agglutinin disease or it's a benign thing. So what is the significant titer at which you should do, and how difficult is to perform a titer in a laboratory?
So cold antibody titer, performing cold antibody titer is not a very difficult job, right? Right. But it is a benign or it is a pathological or non-pathological, it is very important. And even it is very beautifully given in the ABB and the harmoning also, how you can differentiate. And if it is a very clinically significant cold AIHA, always you should start with autoagglutination. Directly don't take the cell and serum and start working. Just have a look onto the sample, right? Just visual thing is also very important.
Right.
So in most pathological cold AIHA, right, you will get a autoagglutination.
Right.
You should not miss that, because once you see autoagglutination, a lot of things will come to our mind. It may be pathological. In most of the cases, it is pathological. The titer will be more than 64, right? Which is the cutoff between non-pathological and pathological. Other important thing is that you may land up with a blood group discrepancy.
Yes.
So once you see it is the autoagglutination, always give an alarm to the technical staff, to the cross-match staff, or whoever there, and to the immunohematology, advanced immunohematology lab. See, this is autoagglutination. You may face a lot of discrepancy in all the steps. Okay, so you should go for a pre-warm technique or something, right? That is the part. And secondly, to differentiate what you have said, it is the I autoagglutination, it is the titer also, 64 or more than 64. Just I am quoting the ABB thing, right, 64, 64. Because if you test my serum for a cold antibody, I may also test positive, 1+ or something. Maybe my titer is 1 in 4 or 8 or 1, but that is the normal thing. Because our serum contains IgM, we sometimes may
Cause
show a
this.
titer. Okay, but always it is always wise to see the pathological and non-pathological part and autoagglutinating part. And titration, I basically do titer by test tube technique.
Right.
I am more comfortable on that because in automation, I have given responsibility to the machine.
Right.
So I don't know whether the machine has done it correctly or not. Even there are validation study or something. But at the back of the mind, what I do with my hand, I know I have done it.
Yes. We cannot substitute for that.
Yes, substitute for that. But yeah, once you have validated the thing with your existing automated titration and your manual thing, then okay, that is good.
Right.
But always you can put a control, right? So negative control, you can put a cord O group.
Right.
Which cannot have a small I, right?
Yeah.
And for the positive, always you are using a pooled O capital I, because 99.9% will be capital I, so you can use a pooled O.
Right.
And always do the titrate at 4 degree and see the reading. And reading can be again, she is saying no sir, it is 128, you are saying no, it is 256. So always there should be no any error in that, right? So an expert I should read that, right?
So two very important things you mentioned, if I may just reiterate. One is that the titer needs to be performed at a cold temperature, that is 4 degrees Celsius. You are doing a cold agglutinin titer, so temperature is very important, and the user, the one who is actually performing and the reader should have a relative expertise in that. You cannot, I mean, you will not be able to perceive if you have not seen it well. So, and that too, if you are saying that there should be two users who will be independently, observing the
thing and put the
yeah, so that is nice. So I think we have covered most of the things. The one last thing which I want to, it is my desire that I also want to know your opinion on, which you are very passionate about, I am aware, is the drug-induced hemolytic anemia. And so how do we diagnose the same, and how relevant is the history in these cases, and how do we differentiate it from AIHA?
Yeah, actually, if you see the working protocol of a DAC workup, right? So always we don't start the DCT in the first go, right?
Right.
You take the sample, you have got the sample, okay? Then there are two parts on that. One is the clinical investigation, laboratory investigation, right? Laboratory investigation, you should have your hemoglobin, hematocrit rate, LDH, haptoglobin if it is available, bilirubin, all the hemolytic markers in one place. In the right side, clinical part, you have to take a history, because you have to take a transfusion history, you have to take, you have to have a clinical examination of the patient, like there will be organomegaly, long-term fever, or the spleen enlarged, right? There may be a palpitation, there may be a dyspnea, a lot of clinical findings are there, a wide spectrum clinical findings in AIHA, right? And number three is the drugs, okay? But nowadays, what I feel, initially during our student days, when we are doing MD, there are 5-6 drugs which you used to know, right? But if you come today, those drugs are not in the market now.
Yes.
But if you go through the 2017, 18, 19 literature on drug-induced AIHA, you will get a lot of drugs which are used in endocrinology, which are used in cancer pathology, oncology, right? So oncology. So even it is said that this diabetic, anti-diabetic oral hypoglycemics, they also cause drug-induced AIHA.
Oh.
Even very common oncology drugs which are used, right, by the medical oncologist, okay, and then the hematologist, they also can cause your drug-induced AIHA. But the picture, if you see the serological picture, it is almost like warm AIHA, but your DAT will be positive in the presence of the drug itself. So getting the generic molecule of the drug is very important. Whether you will be getting it in your pharmacy or in the scientific shops or not, right? That is very important. In many times you get the commercial drugs which does not work actually on that. So it becomes very challenging to do a drug-induced AIHA. Otherwise, the protocol is not very different, but you need the drug per se mixed with the serum and then test the thing, right, to get the DCT done, right? But that is challenging in most of the time. We tried. We tried with ciprofloxacin. We tried with methyl dopa and other antitubercular drug, quinine. Okay, quinine. So we have tried, and we have got few results also, right? But nowadays it is very challenging because patient is taking 15 medications.
Yeah.
When
So pinpoint
is very important. And if you see out of 15, 5-6 are may cause drug-induced AIHA.
Yes.
So it is very difficult.
So what is the role of elution? Can we, if DCT is positive, and what will be the result of an elution study in this case?
Yeah, elution usually for drug induced don't go for an elution, right? Because it is very difficult to get the DCT positive without the drug molecule, right? And even if you get a drug molecule, the elution sometimes is very actually confusing. Okay, if it is a 3+, 4+ with the in a drug induced, sometimes the eluates are negative. Negative. That is the thing. But if you get a eluate, it can be as a conventional AIHA, warm AIHA. But in most of the cases, it tends to be negative.
Right. Yeah. So in drug induced, you will have a DCT positive, eluate negative.
Yeah.
In most of the cases. So I think that you have covered most of our doubts, and I can see that you are very passionate about it, and you can talk for hours together. But I think we have covered most of the questions here, and thank you so much
for the budding this
transfusion medicine specialists.
Transfusion, because in the clinical practice you need a transfusion in AIHA.
Yes.
So you should not, you cannot let a patient die, right?
Right.
So always you should go for the proper transfusion in the AIHA. So there are defined protocol how to issue blood to this.
Like least incompatible blood.
Least. We don't call it as least incompatible now. Best match. Okay,
that is the
term. Or you can go for an phenotype match also, but in our country phenotype matching is a challenge, right? By the time the patient has received your hospital or reached your institute or in your department, by the time 10 transfusions has been given elsewhere, so phenotype is not possible. So you have to rely on the best match blood. But there are some protocols to follow in giving best match blood. But I will tell you, out of the 100 transfusion best match, 99 will be uneventful.
Great.
Okay. So that is the assurance I can give.
Yeah, that is nice. That keeps us going, and clinicians can still, call us and ask us for providing the blood, and keeps our jobs safe.
Always in the cross-match sheet, do write. It's the best match unit. Please transfuse under close observation, close for and check for your urine coloration, and you can perform a biological cross-match. That is after transfusing 30 to 50 ml. You can take a sample from the other hand, send the vial to the blood bank, and you can do a centrifuge. You can compare the supernatant color of the transfused sample with the pre-transfusion sample, and if you see there is the okay, then it is
going well. Yeah, and sometimes we have to always when we have a warm AIHA, we need to check for an underlying allo antibody so that we can give the blood.
Right. And if you are dealing with a cold AIHA, always I will tell you, if it is indicative of paroxysmal cold hemoglobinuria, if you are thinking of that, particularly PCH, so particularly in small child having a viral sickness or some other listeria or other things, bacterial infection, so you have to then rule out PCH. But then you have to do a DL test, donor test. It has a different protocol to do in dual temperature, right? So that should not be missed actually. For all cold AIHA, it can be cold agglutinin syndrome or PCH. So if it is PCH, you see what is the age, what is the underlying history giving, then you have to go for a PCH, donor test.
Right. In earlier days, I remember that we used to always ask a history of syphilis in these
cases.
But nowadays it is uncommon. But yes, there are other cases in which it can come positive. So thank you so much, sir. You were very helpful, and it cleared so many of my doubts. I am sure it has helped the budding DNB or transfusion medicine specialist as well.
Yeah.
Thank you so much.
Okay.